I guess you can get started, Nika.
Okay, great. Can you hear me okay?
I can hear you perfect.
Great. All right. Well, hi, everyone, and welcome to today's session, highlighting experiences on health facility emergency preparedness in fragile settings. My name is Nika, and I'm with the Momentum Integrated Health Resilience team. I'm going to get us started today. We're excited to present this session representing one of 6 projects within USAID's Momentum Suite of Awards. The Momentum Integrated Health Resilience Project works to strengthen health resilience and continue providing high-quality, respectful maternal, newborn, and child health, voluntary family planning, and reproductive health care in fragile settings.
Nika, remember that we have translation. You have to pace yourself a little bit more. This is a little too fast for translation.
Okay, thank you. For today's session, we'll begin with brief introductions and an overview of what a health facility emergency preparedness and response plan, or you'll hear in this presentation, EPRP, involves, how it was operationalized in Mali and Niger, and an in-depth look at the process, experience, and outcomes of developing EPRPs in South Sudan. There will be opportunity for Q&A at the end. So to introduce today's panelists, I'd like to call on Mr. George Manga. He holds a Master's of Science degree in public health and has over a decade of developing country experience in health, nutrition, WASH, and protection programming in sub-Saharan Africa, with notable experiences in Uganda and South Sudan. He has particular skills and interest in system programming, policy development, program management, service delivery implementation, and research within the context of health and nutrition, WASH, and protection systems reform. George has worked on USAID-funded projects since 2011 and now works as the Resilience Advisor for Momentum Integrated Health Resilience in South Sudan. Ms. Ismail Bermad holds a degree in aid and development and a Master of Research in Disaster Management. She has over 25 years of experience in disaster risk reduction and resilience strengthening as project manager, consultant, and technical advisor. She has worked in Asia, Latin America, and the Caribbean and Africa. She has led and supported a diversity of resilience activities and processes ranging from strategic planning to program design, advocacy activities, and evaluations. But her particular interests and strengths are linked to the development of technical guidance for practitioners and capacity development. Isabel is the Resilience Advisor for Momentum Integrated Health Resilience at the core level. Thanks you all for joining, and I'm going to pass it off to my colleague Isabel to get us started.
Thank you, Nika. Good morning, good afternoon, everybody. So in the different contexts of fragility where our project works, crises and disasters like outbreak of violence, flooding, and epidemics are frequent, and they pose significant and additional threats to the ability of local health facilities to maintain their operational capabilities and provide essential and basic health services like family planning, reproductive health, and maternal, newborn, and child health, while also responding to surge in health needs during those crises. In this context that we started this is in this context that we started developing in end of 2021 a process and a tool to support local level health facility to both plan and prepare for service continuity and emergency response. We called it the Health Facility EPRP, or Emergency Response and Preparedness Plan. After developing our first version of the tool, we also discovered that WHO had just released a testing version of its own guidelines for health service continuity planning for public health emergencies. We realized there were a lot of similarities, which can be expected, of course, but also some differences. I think the link of the WHO document is in the chat. Next slide. No, this one, sorry. Stay on this one. So the objective of the health facility EPRP in the short-term objective of this process and tool is to accompany health facilities in developing functional emergency preparedness and response plans. On the medium term, through the testing and iterative improvement of the plan every year, we are hoping to reduce the disruption of services, and then by ensuring basic services are continued at all times. Sorry.
We lost your sound, Isabel.
Yes, I'm back, sorry. So we, through the reduction of disruption of service, we're hoping to build trust between service providers and users, and so increased utilization. And the long term, we also try to reduce morbidity and mortality. Next slide. So these are the main sections of the template we designed for the health facility PRP. It includes descriptions of the health facility and its catchment area, the responsibility under the plan. Then there is a major section on risk assessment. Next click. Which includes listing all potential hazards, developing hazard maps when necessary and possible, developing a specific analysis of potential disease outbreaks for the area, prioritizing the risks, and then developing risk monitoring indicators and thresholds for the most critical risks in the area. Next click. So then it looks at the capacities to respond in terms of resources and assets, both at the health facility level, but also within the catchment area. And this includes non-health related resources too. Then it has different tables to describe and detail both the continuity plans and the response plans. Finally, it has a section detailing the operational and financial plan that complements both continuity and response plan, and a section on the different multi-sectoral and multi-level coordination mechanisms existing in the area. Next slide. So this is an example of template for the continuity plan. Sorry, you cannot see very well. But there is an important aspect to mention here. As you can see in the top left side, we encourage to develop several plans, each based on a specific risk scenario. So at the end of the risk assessments process that we do, we usually need to identify the most critical risks. And for the planning, that we'll be using for the planning. So we could either do an all hazard plan without specifying any hazard, or develop some plans based on specific scenarios. We discussed it as a team, and I decided that for the moment, we are testing the plans based on specific risk scenarios, which could also be multi-risk scenarios like flooding combined with an epidemic under high insecurity time. And this because the external constraints faced by health facility during epidemics or during an outbreak of violence could be quite different, and they would require to put in place different types of modalities. But this could change between scenario-specific and all hazards. We could change as we continue to learn and evaluate from the experiences. So in this table that was developed and agreed, this one by the Ministry of Health in Mali, you can see that we have listed the most critical services that need to continue during emergencies. This is very much aligned with the minimum initial service package, the MISP, and was also inspired by the work on sexual and reproductive health preparedness done by the Women's Refugee Commission. And I think, yes, the links are in the chat. Next slide. In terms of process, the idea was first, during the second year of the MIHR project in 2022, to do a training of trainers or facilitators at country level, with a maximum of participants coming from the Ministry of Health and other stakeholders from local actors involved in providing health services, but also representatives from organizations involved in other sectors, but in preparedness. This was supposed to be followed by a workshop at health facility level where the plans would be developed and then tested and improved 6 months later through a simulation exercise. The following year in 2023, we did an after-action review in each country, and then we were supposed to organize a refresher and adaptation training based on learnings from the previous year, and finally continue and scale up the process. Of course, this did not happen exactly as planned, but quite close enough. So now let's look at what happened in Niger. Next slide. So next slide. So in Niger, we had a first training of trainers in April 22 with about 23 participants, but only 2 plans developed the same year. In 23, after an after-action review, we decided to propose a new format where we merged the EPRP into the formal and routine planning process of the health facility, called the microplans, that the health facility have to do every year anyway. So we added parts of the EPRP template to the Niger microplan template, mainly adding the sections on risk assessment, continuity and response planning, and preparedness plan. We add another TOT, a training of trainers, in March, and in April, the facilitator organized themselves and then facilitated the development of 46 plans between May and August. Next slide. So among the main lessons learned and successes is that the second version was integrated into an existing yearly and routine planning process, which we think it would be key for future sustainability of the process. One of the main issues was the underestimation of the time needed for both the training of trainers and the health facility workshops. Next slide. So for the case in Mali now, so we have a health resilience advisor in Mali as well, and he attended the training of trainer in Niger in 2022. So when he came back to Mali, he by himself facilitated the development process of 20 plans in the Gao and Timbuktu regions with mixed quality results. In April 2023, we were able to organize a training of trainer / kind of adaptation workshop in Mali with the Ministry of Health and other key stakeholders, where we adapted the process and template of the EPRP. And since then, 10 plans were further developed by the trained facilitators. Next slide. So among the main successes and lessons learned in Mali was the importance of the involvement and the leadership of the technical services of the Ministry of Health in the adaptation of the process and template, and really encouraging the national ownership of the tool. Again, there was an underestimation of the time required to both conduct TOT, the training of trainers, and the health facility workshops. Next slide. So here is one of the success stories from Mali, where the technical director of a health facility mentions the difference in the preparedness level of the health facility when facing flood. So he said, I will quote, last year at this time of the year, the health center was not prepared to deal with disasters. And when a village was hit by a flood, the health center was also disrupted because of the workload. And during this time, the families of the victims complained daily about the quality of service provided. This year, after the development of the plan with the support of the MIHR project, the staff understood the importance of having an emergency preparedness plan. It was activated after the flood to better structure the health center to meet the need of the disaster victims and at the same time ensure the continuity of service. So this concludes the experience in Mali and Niger, and I will now invite Dr. George Manga to describe the experience in South Sudan. Thank you.
Thank you so much, Isabel. Good morning, good afternoon, everyone. I'm going to share our experiences in South Sudan with the health facility emergency preparedness and response planning. Next slide, please. So in South Sudan, we started with the preparation of the manual for the trainers, for the TOT. After the manual was developed, and then we invited all our county project officers together with the county health departments that were representing the Ministry of Health from all the 6 counties. And we invited 12 participants, and they were trained around January 2023 for 3 days. And that was followed up with the rollout of the training to all the 6 counties by then. And in the counties, the participants that we invited for these trainings involved the health facilities staffs, representatives from county health department, NGO representatives, community leaders, representatives from Relief and Rehabilitation Commission, county authorities, and we also have cluster representatives because if disaster hits, it affects all the sectors. And the rollout was done between February to May 2022 to all the 6 counties. And we were able to come up with the 13 plans for the 13 health facilities. And we did simulation for 1 location, that is WOW. We pre-tested the tool using the WHO tool. Rather, we pre-tested the plan using the WHO tool, such that it give us insights for developing the simulation, rather the checklist for the simulation exercise that we plan to do after 1 year. And now the 1 year has ended, the checklist is ready. So once the PY4 funds are ready, we'll immediately start doing simulations for all the 13 health facilities. Next slide, please. So as Isabel mentioned earlier, these were the areas we use for developing the plan, looking at the main characteristics of the health facility and also looking at the main characteristics of the health facility catchment area. We look at the responsibilities under the plan. We also do map the risk assessment and monitoring. Then we look at the resources and assets in terms of the gaps and what is in place. And then we look at the continuity and response plans. Like in continuity, we look at, for example, if there's flooding, what are the modalities in terms of whether activities can continue as a static or to do outreaches. And we look at the needs, what kind of personnel do we need, equipment, infection prevention and control, definitely need budgets and responsibilities under that. So we also look at the operational and financial support plan, where exactly this is coming from. Then we map the coordination mechanisms for both non-emergency and also the emergency coordination mechanisms, the people involved, and that would help us in case of disasters to easily coordinate the response. And then in all the 6 counties where we developed the 13 plans, most of the risk scenarios together with them that the plan was developed for were disease outbreak, flooding, economic crisis, there is conflict and security, there is drought, and also there is fire. And this varied from county to county and also from context to context. Next slide, please. Yeah, so when we look at some of the positives or the successes in developing the process, we realize that the participatory approach or method of engaging the stakeholders in developing the plan was very successful because everybody was engaged and were able to make good use of their institutional memory. And then we made sure in the preparation we identified the conducive environment, and also we made sure we had the 2 note takers who could note some of the important points down and keep the participants active by having an energizer. And we made sure most of the stakeholders were engaged from almost all the sectors. And then together with them, we were able to develop the next steps for the planning. But also towards the end of the planning workshop, they did an evaluation, and then as per the result, they were more satisfied. And also the knowledge acquired was good based on the evaluation. And then the post-test results compared to the pre-test. And then the training did not only focus on project-supported health facilities. So that was one of the successes because when disaster hits, it affects all the locations. So during invitation, we made sure the county health department invited not only the staff that momentum support, but also facilities in the catchment area, such that they can use the knowledge to also develop their own plans. And then health facility in charge with their teams are more confident to respond in case of emergency after the development of the plan. They said they are well equipped. They feel whenever now there is a shock, they are well equipped and they're able to respond accordingly. However, there were a few issues, and one of the issues was they felt the 2 days for the workshop was not enough, and it should have been added more for future trainings. And then they also felt not all well facility staff participated in the plan development because, of course, the facility cannot be closed so that the staff comes for training. Therefore, others have to continue providing services while others gain the knowledge. And then they were tasked to go and also pass to their colleagues. And then health facility emergency preparedness and response plan apply to lower health facilities excluding hospitals, and yet they failed. Also, the hospitals have to be included, though it is a higher level. And then also, in terms of transport refund, especially to the county health department, was a challenge because that was one of the expectations, and we are restricted as per the policy to give money to them. And then also there were logistical arrangements challenges. Next slide, please. So in terms of lessons learned, we realized that it's really paramount to increase the number of workshop days to 3 or more in future trainings or workshops. And then for health facilities that are very far apart, trainings can be extended to the health facilities and involve the staff when patients have cleared. And then also they said there was completely no health facility emergency preparedness and continuity management plan, and so this was first of its kind, and it was a great opportunity for them to be part of this training. And then one lesson also that was learned was the importance of rather multi-sectoral approach to strengthen preparedness, because whenever there is a shock, like insecurity in a location, it affects everyone in that particular location. And then in terms of the approach, it is really highly accepted, not only the health facilities, but the county health department, all the sectors, they were happy, and they feel this should not be only for those locations where MA operates, but it should go beyond the areas of MA operation, and if possible, if resources could allow, it should be for the whole country. And then also the participatory nature of the workshop offered room for sharing experiences, because the people invited we used the selection criteria, and we really brought people who could give us knowledge, and we got enough from their institutional memory. Next slide, please. So in terms of other information, especially the cost of the training of trainees, cost around $5,200 US. And then for the consequent trainings for the rollout in the counties, it costs roughly $2,443. And then the average time for developing the plan in those counties was 2 days. And then in terms of average level of effort from the facilitators, right from the pre-workshop preparation, co-development of the plan and dissemination, it took roughly 5 days. Next slide, please. So this was one of the successes in South Sudan in an area called Bor. Towards early this year, there was a heavy flooding in one of the neighboring counties in Bor, and around 16,000 people were displaced as per the needs assessment. And then they came closer to the facilities where MA operate. They were internally displaced. And as part of the developed emergency preparedness and response plan, it was activated. And then a team of Momentum, a team of county health department, a team of Live Well, some of the community leaders and representatives were able to do integrated health outreach for EPI, family planning, immunization, and also nutrition. and that was in the Bor area. Next slide, please. And then also there was one of the successes was the case of Ebola outbreak in neighboring country Uganda. And we had the counties that we support at the border, at the borders to counties that are at the border to Uganda. And we had already developed emergency preparedness and response plans in the facilities in those locations. But because of frequent movement at the border, so we had to call people, and people had to be vigilant. So through the county health department, we activated the plan, and then partners were called to do micro planning to review the already developed plan. And then they had to review it to fit it EVD. And following that, our health facility staffs were trained on EVD, and even risk communication was done through house to house by Boma health workers and also in schools. As you can see in the picture, one of the pupils was practicing hand washing following the risk communication in one of the schools in the Kajokeji. And thank God the EVD didn't reach to those locations where we were operating. And these were all attributed to the already developed plan in those locations. Thank you. Next slide, please. And then one of the successes also was in Imagui following development of the plan, the health facility emergency preparedness and response plan. There was a heavy rain with wind and hailstone in one of the locations called Imagui. 171 homes were destroyed. 17 community members were heavily injured. And then the health facility emergency preparedness and response plan was activated. Relief and Rehabilitation Commission office was informed. Partners were called for a meeting. Then they sent a group to go and do needs assessment, and based on the report of the assessment, more medications and health supplies were delivered to the location, including the health facility. And also partners came together, they offered integrated health and nutrition outreach in that particular location. Their partners also delivered tents and temporary toilets. And then also water treatment tablets for the worst partners. They also distributed in those locations to reduce waterborne diseases. And then the health facility, of course, remain open by assigning more staff. This is as per the, we talked to the health facility in charge, Mr. Ochen is the health facility in charge for Bo PSCC. He said the health facility remain open. He was able to assign staffs. They were able to do task shifting, and then they were able to practice triage without discrimination and ensure community members continue accessing health services. And all this was made possible through the emergency preparedness and response plans for the health facilities. Thank you. Next slide, please. So in the next steps, following the development of the 13 plans, one of the key breakthrough was that WHO actually, who is the custodian of the Ministry of Health, we've been having a lot of meetings with them. They have shown a lot of interest in our tool, and they were very eager to learn from us. And then as we talk now, they already adopted our tool because they had a tool which is called STAR, which is strategic risk assessment. And for us, our tool looks at not only the risk profiling as per their STAR tool, but we also look at, apart from risk profiling, we also do preparedness and response planning. So we merge the two tools, and it's already adopted, it's already MOH tool, and it's going to be piloted in the Central Equatoria State for 2 counties of Juba and Kajokeji. And after that, it will be for a countrywide rollout. So that was one of the breakthrough. And then also we have developed checklists, supervision checklists that we are going to use, because like in the adaptation of the tool, our contribution as MA is to monitor usage of the tools and also give technical support where need to be, especially in the trainings of the participants and also development of the plans. So we also developed checklists for simulation of all the 13 health facility EPRPs. And then we've already expanded to 2 locations of Ju River and Budi. So we are going to also develop new plans for health facilities in those locations. Next slide, please. So thank you. I'll take it back to you, Nika. Thank you, everyone.
Thank you so much, George. That was wonderful. That was really helpful, I think, to give everyone an understanding of some of the more detailed parts of the process for implementing EPRPs in fragile settings, especially particularly South Sudan. I have a few questions before we move to the audience, but I was wondering, Isabel and George, in these examples, you know, we've talked about and focused on the health facility level and how we apply EPRP at this level. Can you maybe talk about what other levels EPRP can be applied, and does every level need to have an EPRP, or kind of how does that reconcile across levels? Over to you.
George, do you want to go ahead for South Sudan, or should I?
Yeah, no problem. I can go first. Well, for momentum alone, we did our health facility and mass preparedness response plan, looking at the fragility of South Sudan. The major idea was to ensure service continuity. The family planning, the RHA, the MNCs, and the nutrition services that we provide through MAMI, we want to ensure that in the eventualities that there is flooding, there is insecurity, there's disease outbreaks, still they should be able to continue providing services. That was the idea of it. And we did ours, we narrowed it to the health facilities and the catchment area. And of course, right now, what WHO is doing is to do it for the whole state, not only a small unit of the health facility and the catchment area, but the whole state. So it's going to be for the whole state. And after piloting Central Equatoria, and then we plan to do it together for other states. And Momentum is going to be part of the steering committee. They will co-facilitate the steering committee together with the Ministry of Health. So those are our next agendas. Thank you. Isabel, if you could add something, you're welcome.
Yes, thank you, George. Indeed, so maybe something to clarify as well. We are, when we develop the health facility plan, we are normally ensuring that we have representatives for the wider disaster risk reduction or disaster risk management organization or agency that are represented and participating in the development of those plans. And another thing is that normally we also make sure that we share those plans with horizontally and vertically within the health department, but also within the other national disaster management agencies, or in some countries it's with the early warning and response system departments of the countries, where we ensure that there is coordination, horizontal and vertical coordination. We are not really supporting the development of plans at higher level for the moment, but we are developing at lower level. So within health facility catchment area, we are also planning the development of, facilitating the development of community action plan for health resilience. That will also be linked to the health facility EPRP. And so we are starting those processes in South Sudan, in Mali, in Niger, and we will also expand to other places. We are also expanding this year the health facility EPRP in DRC, and where we also be working at community level on community-based action planning for health resilience. But in DRC, And in Mozambique, we are also doing another type of activity with on sexual and reproductive health preparedness, where we are using, and that's at another level, that's at the health zone level. So a health zone is comprised of various health facility and their catchment area. So that's the level above. And so we are supporting as well MIHR, the development of plans that will cover the health zone, but also the zone below. And we are planning to compare those type of approaches as well, and evaluate how those approaches, if we start at health zone, health facility, or community, which one or both combined are effective, and so on. So that's the plan for learning in the next years of the project. But all the time, we try to always have a multi-stakeholder approach and involve all the important actors in humanitarian response.
Thank you both. Those were really insightful responses. I think, Isabel, one thing that you just touched on was, the inclusion of multiple people. And I know that was one of the challenges we discussed in this presentation, was overcoming things such as participant commitment restraints, if staff weren't available, potentially a lack of financial resources. Given some of these challenges, George and Isabel, that were encountered in the process, how would you say, how did these teams kind of overcome those challenges, and maybe what were the most important facilitators for success? George, we can start with you.
Sorry, come again. I didn't pick it very well.
The question is, how did we overcome some of the challenges related to things such as unavailability of staff, lack of financial resources that were outlined in the presentation? What would you say were the most important facilitators for success?
Well, thank you so much for that question. In terms of unavailability of staffs, it's not that the staffs are not there, they are there, but then as we mentioned earlier, we cannot leave the health facility open. Services have to continue. That's why representatives are attending this development of the plans. But then also later on, the knowledge is passed to them as well. However, in terms of financial and operational support challenges, we talked about multi-stakeholder engagement, and also ensuring integration of all sectors in the development of plans, such that they engage early right from the development of the plan. And then at the end of each plan, there's responsibilities attached. And they are part of the committee for emergency preparedness and response in those particular locations. And they meet monthly to review those plans. Not only the health facilities, the one reviewing the all stakeholders, the list of the people who are involved in the development of the plan, and also the committee that is formed. They review the plan monthly, and all these plans are linked to the Central Disaster Risk Management Unit. And so if they have any meetings there, they also update the central unit. And the idea of this is such that in the eventualities of shocks or disasters, resources can easily be coordinated for response. And that's why even when they are doing the needs assessment, they go jointly as all the partners that are involved in the preparedness and as well as in the response. So it is everyone's responsibility, not only the facility, not only the county health department. It's well coordinated up to the central level at higher level. Thank you. Over to you.
Thank you. Isabel, anything to add?
Not directly on this one, but I saw different other questions in the chat and in the question and answer box.
Yes, please, go ahead.
I'm not sure which one to start with.
Why don't we start with Bergson's question in the chat?
So what are the different strategies that have been put in place for the appropriation of these plans by the different stakeholders in general, and in particular, the community? So usually that's a very participatory process, and both in Niger and in Mali, one of the first in the training of trainers section, when the first training session is about the stakeholder involvement and stakeholder analysis and involvement in the process, to really promote a multi-stakeholder approach. And so for each time we do the health facility workshops, or whether at the health facility or for the health facility, we make sure normally that a wide range of stakeholders are involved from the beginning and participate actively in the planning. And then there is a dissemination mechanism after also. So that's the main point, is about involving them quite early in the process. So for the moment, we don't have, it's still an early process, so we haven't had the time to evaluate and this specific part, we haven't either looked at other ways to improve the appropriation by different stakeholders of those plans. But that's something we will continue working on.
There's also another question.
The second part of the community. So that depends what you mean by community. So we for the different community levels, that's the next steps that we are working on, is at community level, what we call community in here, it's villages. And so for each health facilities, the catchment area regroups different villages. And so we will also make sure that the health facility plan is also disseminated in those villages, but the villages themselves will go through a process of developing their own community action plans with the support of the health facility as well.
Thank you, Isabel. George, did you have anything to add?
There's another question also. No, not really. There's another question also in the chat from Mohammed Isa. Is asking, you have risks, for example, security, drought, etc. Have you faced any during the implementation, and what have you done to mitigate or adopt? For South Sudan, yes, there was the issue of insecurity related to cattle raiding, abduction of women and children in one of our counties in Magui, specifically Abara. And when that happened, we had to ensure also the safety of our staffs. They were removed temporarily to Magui, a nearby town, because so many people moved away. People were internally displaced. But before they went, they made sure they activated the plan. They formed the county health department and also the county authorities, especially the commissioner's office. And then the most important thing they did was they also called us. We also guided them. And then they made sure they secured all the drugs, the supplies, the equipment before they went. But of course, in also the community, we have our Boma health workers that are within the communities. So they move with the community in the IDPs, and they continue providing services to the population with the supplies that they have. But then also later on, partners, after doing the assessment in the IDPs, together with Momentum, they provided integrated, they did the health outreach services. But then also other partners provided non-food items, others provided the temporary shelters like tents, etc. So that was with the insecurity. Though somehow it can be beyond the organization, but there are certain things we can do to ensure services continue and also to reduce the impact of that shock on the health service delivery, access, and utilization. Thank you. But for drought, Yes, it did happen, but it didn't affect the service interruption. So services continued normally. Thank you. Over to you.
Isabel, anything to add to that about how you overcome any risks experienced during the process?
So, I mean, yes, so we presented several success story because indeed we experienced some hazards and risks, and then the plans were activated. But the second part of the question about mitigating or adapting, I'm not sure if it's the term adapting or adopting in the sense, I mean, adapting an adaptation on the long term or mitigation in the terms of disaster risk reduction, which goes further than just preparedness. With those plans, we first focus on preparedness. And so, yes, there are some action beforehand to make sure, for example, in Mali, they also want to link, and at community level, the issue was more on accessing funding to access health facilities during emergency, and so they are supporting also village saving and loans association types of groups to make sure that there is emergency funding for when there is an emergency, and but that's more for preparedness. They're also organizing, pre-organizing transport or things like that for during an emergency. But that's not mitigation or adaptation in the sense that on disaster risk reduction would look at them reducing the risks on the long term. We might identify some of those actions, but that will be more when we will be working at the community level and the community action planning for health resilience, where not only communities would be trying to identify the preparedness actions for a quicker and a more effective response, but also what they can do to also reduce their risks, their exposure to different hazards they're facing.
Thank you, Isabel. Thank you, George. We have a few more questions in the chat. One of them says, are facility health plans and needs aggregated and rolled up to a central coordination point, like a disaster management agency or ops center, or are they more standalone and facility specific?
So we have already answered this question at the beginning.
Okay. Can you give a brief for maybe those who weren't able to join at the beginning?
Yeah, repeating our answers. Yeah. So yes, the quick answer was yes. We try to, as much as possible, we try to have like a vertical and horizontal coordination, and even vertical. It's within the health sectors, but also with the other sectors that are involved in emergency preparedness and response.
Thank you, Isabel. Another question in the chat says, I appreciate the success stories. What is the most efficient way that you have found to document the process at a given facility, which enabled the highlighting of the way that APRPs were implemented, which resulted in the case studies? Do you have more detailed case study documents?
We have a few case study documents that we've showed today. There are very basic templates for collecting success stories. They are not yet in depth. We may want to expand that, but we've only had only 1 year of experience, and for the moment, that's how we collected the success stories. But because we are also soon developing a kind of evaluation protocol, we will develop more rigorous tool to collect learning from this process. of which we'll be learning after each time a plan was activated. And so we might have more case studies or success stories maybe as well on those things, but we are still developing them. Thank you for the question.
There's also another question from Anaklek saying, thank you both for a good presentation. How was the population in the catchment area of the health facility involved? Well, the involvement is that I don't know if this is during the preparedness or in terms of response, but what I can say is in the plan development, yes, the community were involved, especially the gatekeepers, the chiefs, the religious leaders, the teachers, the key opinion leaders, the elders, people with the institutional memories were involved, because we need the people who know their context very well, such that the plan will be developed based on the needs of that particular community. So they were involved in the development of the plan. But then also, when it comes to the deep in the communities in the catchment area, also for the other community members, we developed community action plans based on the priority scenarios identified in those locations. And the community action plan will at least help build their capacity of the various SOCs within their catchment area and what they can do with the available resources within their vicinity to reduce the impact of that particular SOC before aid comes from the government or from the partners. And that was how they were involved as part of multi-stakeholder engagement. Thank you.
Thank you, George. One question too, as we close out, I would like to call on Isabel and George to respond based on their experience. If you were to give another similar setting one piece of advice for implementing EPRPs at the health facility level or at another level, what advice would you give? Isabel, we can start with you.
So that's an advice I would give to myself as we are expanding to new countries. So we'll be expanding in DRC and potentially in other places like Sudan or Burkina Faso or Tanzania. So the question is the recommendation will be to see if there is already a system existing. Of course, most of the country where we work, there is no such thing as an health facility, PRPs, but the health facility has some level of yearly or routine planning, more or less developed, and then try to use this and start with this kind of planning to build on the health facility EPRP. That would be my first advice. My second advice would be really to, from the beginning, also work with the technical department of the Ministry of Health and review a generic templates and make sure that it's well adapted to the specific country and align with what exists already in within the National Disaster Risk Management agency of this country, because they already have some kind of thing. So it's both trying to adapt the EPRP to what already exists at the national level in terms of emergency planning, but then also link into the routine planning of the health system in the country. That's where you would have, I think, the most success. Thank you.
Thank you, Isabel. George, your advice?
Well, thank you. I think Isabel mentioned most of the key areas for success whenever this is to be extended to other areas. But what I would add is the stakeholder engagement right from the beginning. It's very important, and it has to be multi-sectoral, not just only the health sector. And right from the beginning, engaging all the stakeholders is very, very important because that brings the aspect of engagement and also the ownership for purposes of acceptance and also sustainability at the end when momentum leaves. Thank you.
Thank you both so much. We're going to start closing out our session today. Thank you all from the audience for your thoughtful questions, and to our panelists for your very thoughtful answers. Today, our panelists really demonstrated how emergency preparedness and response infrastructure is a critical component to not only ensuring service continuity, but also for building health resilience, which is an integral part of the Momentum Integrated Health Resilience Project. It is our hope that today's session provided key insights to how these EPRPs are operationalized at the health facility level in fragile settings, and also at other levels, and how they can really be used to improve short, mid, and long-term health outcomes. With that, we want to thank you for joining us today. The recordings from today's session in every language will be posted to the Momentum YouTube page, which is shown on the right. We hope to see you again soon. Thank you so much for joining us.
Thanks, everyone. Have a great day.
Bye.
Thanks, everyone, for your time. Bye.
Bye-bye, everybody. Have a good afternoon. Have a good day, everybody. Bye-bye, Nika. Gracias, chicos. Ya podéis parar la grabación. Bye-bye.